Good morning. Welcome to this morning's lecture on the anxiety disorders. We'll go ahead and share my screen and get started momentarily. Everybody can see the screen okay? Just need a thumbs up, we're good. All right, so this morning we're going to talk about what are now 3 separate chapters in the DSM titled the Anxiety Spectrum Disorders. Here are our stated objectives. You know, as you look at these 1 through 5, there's a couple of points I want to make. What these objectives really achieve, the overall goal is to be able to identify the particular specific anxiety disorders in a clinical setting and therefore on a shelf exam. Number 1, I would like the students to approach questions pertaining to anxiety just different than any other question on the psych and any other shelf that you have ever taken. You know, we've taken tests for our entire career. We know that upon reading through a question, we have a general idea of what is likely going on. We take a peek at the answer set, go back to the question, read it a little closely, then choose our single best answer. If you apply that same strategy to a question related to anxiety disorders, you are putting yourself at risk for getting the question wrong. These questions defy that type of test-taking strategy, and a primary reason why is because there are just simply too many overlapping signs and symptoms. So I would suggest that upon reading a question that pertains to the anxiety disorders, once identified as such, read the question itself in its entirety and read it closely. And in doing so, begin to look specifically for details that separate one anxiety disorder from another. That way, you won't get derailed by the overlapping principles. So these 5 objectives really are aimed to achieve that very goal. As mentioned before, the anxiety disorders are now classified among 3 separate chapters of the DSM: the anxiety disorders proper, obsessive-compulsive disorder and related disorders, the trauma and stressor-related disorders. For all of these conditions, the causes are biopsychosocial. And what I want medical students to begin to do is, number 1, not only appreciate this, and again, some very superficial examples are provided on this slide, but in addition to this, also begin thinking about predisposing factors, precipitating factors, and perpetuating factors that can explain your patient's behavior, whether that patient is in vivo or on a shelf exam. So not only biopsychosocial, but also predisposing, precipitating, and perpetuating factors, each of which themselves have biological, psychological, and social components to them. Here is our list of the anxiety disorders, 1 of the 3 chapters, followed by a list of the obsessive-compulsive and related disorders, then finally the trauma and stressor-related disorders, all of which we're going to review today in a bit more detail. We did have a couple of movies assigned for tomorrow. We're going to discuss Jaws in the context of what we're learning today, as well as the film Vertigo. I resisted every temptation to assign a Shakespearean film. The feedback I get usually from medical students is that Shakespeare is not among their favorites. However, with my success in avoiding that assignment, I do want to reference a couple of the Bard's ghost passages. Primary reason why is that those tragedies will form an acronym that we will follow and that will provide an outline for all of the anxiety disorders from each of those 3 chapters through today's presentation. First and foremost, I want to kind of set the stage and begin discussing aspects of the mental status exam. So this is a routine part of the physical exam that has multiple components you've learned elsewhere, one of which I want to focus on right now, and that is what you're looking at, thought content. In addition to what the acronym will tell us, killer endings, the KE in the acronym in your other PowerPoint that focuses on the mental status exam itself, there is another part of this domain of mental status, usually referred to as themes. So again, thought content is broken down into not only killer endings, SI and HI, but also themes. You see a list of those themes on the right side of your slide, starting with the overvalued idea, progressing through the delusion. For all intents and purposes, what differentiates the overvalued idea from the preoccupation, from the rumination, from the obsession is subjective. The one thing we need to agree upon today is that all of the above is markedly differentiated from that which we define as a delusion. That's that green line across your slide. Here, that is, what separates everything from the delusion is that while not reality-based, the delusion is fixed and rigid despite the individual being presented evidence to the contrary. Okay? If that does not apply, you're not talking about a delusion. If there is some evidence of insight, doc, I know what I'm saying sounds crazy, but ... you're likely dealing with an obsession, a rumination, a preoccupation, or an overvalued idea. Again, which one? Largely arbitrary. There's really little rhyme to reason. And you'll see this with your supervising faculty, often interchanging these terms. One of which I want to discuss in a little bit more detail as it applies to a definition of an illness that you're going to see in your shelf exam, and that is the preoccupation. The preoccupation is what defines body dysmorphic disorder. Now, you wouldn't necessarily be wrong if you said, well, body dysmorphic disorder is a mental disorder defined through one's obsession with having a perceived defect in appearance. You know, you're correct in saying that, but you'd be more diagnostically accurate if you simply use the clinical term preoccupation, in as much as it is the P word that the American Psychiatric Association uses when defining body dysmorphic disorder. I'm pulling this definition, the first bullet, directly out of the DSM. So body dysmorphic disorder, the preoccupation is with a perceived defect in physical appearance, which usually results in repetitive behaviors or mental acts to manifest that very preoccupation. A very common preoccupation is with muscle dysmorphia. And because it is so common, the DSM in its latest revision included with muscle dysmorphia as a specifier. Additionally, there are common specifiers that focus on insight, ranging from good to absent. That is, individuals with this condition, when there are higher levels of stress, can have this form of deficit in thought content, this preoccupation, evolve into a delusion. And then once the stressor is then turned down, alleviated, their deficit in thought content is back to a preoccupation quality. So that phenomenon where biopsychosocial stressors can result in a strengthening of this condition, that evolution from a preoccupation, a milder form of deficit, to the delusion is referred to as stress or stress-induced psychosis. Following now again with the acronym BARD's ghost passages on the bottom left of your slide, they will light up and be highlighted as we move, that is from left to right. The A stands for adjustment disorders. Now, adjustment disorders in general are diagnoses of exclusion. That is, the clinician really must investigate other mental disorders before ruling in an adjustment disorder. By definition, the symptoms must develop in response to a stressor. That is, the symptoms must satisfy the operationalized definition of cause and effect. And it's very important for students to understand how cause and effect are defined by the American Psychiatric Association. In the context of adjustment disorders, cause and effect is established when the onset of symptoms is within 3 months and the offset is within 6 months of acute, or I should say, termination of the acute stressor. That is, if the onset is within 3 months, the acute stressor terminates and the patient presents to your clinic 18 months later, symptomatic, that defies the definition of an adjustment disorder. So again, understand that 3 and 6 month window and how cause and effect is defined by the APA. The symptoms can be anxiety, they could be depression, they could be both. They could be a disturbance of conduct or a combination of disturbance of conduct and mood/emotion. So, and if not any of the above, it would be an adjustment disorder, unspecified type. So again, it could be emotion, anxiety, depression, it could be mixed emotion, it could be disturbance of conduct, or combination of that disturbance of conduct and emotions. Reactive attachment disorder. This is a condition that is new to the DSM-5. This condition was previously in the child adolescent chapter of the DSM. It is defined by an individual who is between 9 months and 5 years, so a child, who is inhibited and emotionally withdrawn. There is social and emotional disturbance, irritability, sadness. That is not attributable to a larger mental disorder such as an autism spectrum disorder or ASD. History of insufficient care is thought to be the underlying cause, and it may be persistent. So again, in a child who presents with inhibited and emotional withdrawal that is not due to another mental disorder, including ASD, reactive attachment disorder should be considered as the single best diagnosis. Disinhibited social engagement disorder, another new condition previously in the child adolescent chapter, is another example of anxiety where the individual, again, a child, in this case, perhaps even an adolescent, but someone who is older than 9 months of age, actively approaches and interacts with unfamiliar adults. Again, this behavior is not thought to be attributable to another mental disorder, including ADHD. You see that the history is consistent with that which might cause the previous illness, reactive attachment, that is history of insufficient care. And again, it also may be persistent. Spelling out the word BARDS, it was very nice and convenient for the R and the D to be juxtaposed in that reactive attachment follows very nicely with disinhibited social engagement disorder. Again, these are child adolescent illnesses, both of which cannot be attributed to other mental disorders. On the left side of your slide, reactive attachment is defined through inhibited, emotionally withdrawn behavior, whereas disinhibited social engagement is defined by the individual, the child or adolescent, actively approaching and interacting with unfamiliar adults. In each case, bottom of your slide, the cause is thought to be insufficient care. And then finally, the last letter in our first word of the acronym, again, bottom left of your slide, selective mutism, another new condition to the DSM that is new to the DSM-5. What defines selective mutism is a consistent failure to speak in specific social situations. That is, in other situations, the individual speaks perfectly or quote unquote, within normal limits. However, in specific social situations, they simply don't speak. They're not speaking. This mutism is not better accounted for by a lack of knowledge with the spoken language or not due to another mental disorder. Right, so selective mutism. Selective mutism is a mental disorder. Specifically, it is an anxiety disorder. Mutism is different. While selective mutism obviously is defined through mutism, mutism in and of itself is a mental status exam finding. Again, keeping with the same acronym, again, from a previous PowerPoint about the mental status exam, ABC stamp licker, the S in the word stamp in that acronym stands for speech. And a mental status exam deficit within that domain, speech, could be mutism. So mutism is a mental status exam finding. It's a physical exam finding. But it also could be defining of a mental disorder, specifically an anxiety disorder called selective mutism. So just want to make sure we get those two terms distinguished. If there's one of the pet peeves of mine that I would wish every medical student learns upon successful completion of their core rotation in psychiatry, it's that generalized anxiety disorder has specific DSM criteria. Many practitioners, including psychiatrists, reserve this condition, generalized anxiety disorder, to an anxious patient who seeks care, AKA is experiencing clinically significant distress or impairment due to their anxiety, for which they can't uncover the specific anxiety disorder. They don't think it's due to OCD. They don't think it's due to an adjustment disorder, etc. Therefore, it must be generalized anxiety disorder, that this condition is somehow a grab bag for clinically significant anxiety that you can't figure out the single best diagnosis. And that is far from the truth. Again, generalized anxiety disorder is a condition that has specific DSM criteria. And if you ever have to remember what those specific criteria are, just think of the combination of major depressive disorder and excessive worry. What you're looking at here, SIGI caps, are the DSM criteria of major depression. Very straightforward. SI, of course, stands for suicidal ideation, guilt, etc. What you see here is an overlap of symptoms shared with generalized anxiety disorder. So you could see how this condition may not only overlap, but sometimes be confounded or confused with a major depressive episode. The SI in generalized anxiety disorder, now getting to the specific criteria that help differentiate this condition from major depression, includes significant irritability. So while people with this condition, that is generalized anxiety disorder, may actually have suicidal ideation, SI is not a diagnostic criterion of GAD. Significant irritability is replacing the SI in the acronym. That said, from a clinical perspective, this is of little help because a lot of individuals with major depression are irritable. And irritability is thought to be a manifestation of dysphoria or depressed mood. So having significant irritability does not necessarily allow one to kind of tease GAD away from major depressive disorder. Generalized muscle tension, though, begins to differentiate this condition from major depression. Now, that isn't to say that people who are depressed never have generalized muscle tension, far from it, but you can see that there is some level or degree of specificity of the G in the acronym for generalized anxiety disorder. What is most helpful, though, is the final letter that completes the new acronym. A does not stand for appetite, as it does for MDD. A instead stands for anxiety and excessive worry. And that, if you remember the slide prior, really helps differentiate this condition from major depression. So a clinical pearl, if you see someone with chronic depression who also endorses excessive worry, please have generalized anxiety at the top of your list, and then feel free to go back and review this new SIGICAP acronym for the diagnostic criteria of generalized anxiety disorder. Hoarding disorder. Again, very nice that this condition goes back to back with the next one we're going to discuss, which is OCD. Again, the H and the O in ghost, those two letters again juxtaposed. Hoarding disorder is defined through persistent and clinically significant difficulty discarding or parting with one's possessions. As a result, there's this need to save items, and there's marked distress when people try to throw things away. The result is that there's accumulation of one's possessions, and you could probably remember the TV show Hoarders, which was very influential of having this condition be pulled out from OCD and have this new condition, hoarding disorder, actually created. That is, hoarding was a diagnostic criterion of OCD until that television show. And because of its popularity and because of the point prevalence of hoarding skyrocketing as a result, the APA had to react and created its own disorder. And so I think it's fairly straightforward seeing here. And like I said before, it's very nice and convenient that this does go back to back with the next condition that we're going to discuss, specifically obsessive-compulsive disorder. Now, whereas body dysmorphic disorder is defined through preoccupations with an imagined defect in one's appearance, obsessive-compulsive disorder is also defined through a deficit in thought content. Although we're going to change the terminology, that deficit is now going to be called an obsession. What differentiates a preoccupation from an obsession? Again, it's in the eye of the beholder, but here we're going to use the O word in defining this next illness, specifically obsessive-compulsive disorder. Now, I want you to be careful here. I think implicit in this discussion is that we need to differentiate this condition, an anxiety disorder, from the condition that exists in the personality disorders chapter, specifically a cluster C personality disorder of obsessive-compulsive personality. Anybody care to unmute and provide what differentiates this condition from OCPD? And I want you to try to answer that question without using the words egosyntonic or ego-dystonic. Anyone?
The personality disorder is when their obsessions align with their values, versus OCD is when a patient has an obsession and recognizes what the obsession is, but that doesn't necessarily align with how they want to lead their life or the values that they have for their life.
So kudos. This is an honors student, because what you just did is you gave me the definitions of egosyntonic and ego-dystonic without actually uttering the term. So you absolutely put one over on me. That is, you're exactly right. But there's more to it than that. So that's a correct answer, and it's an answer that could very well appear on a shelf exam. But there's much more to it. Anybody else want to give it a stab? All right, so let's begin to answer that question by first defining what obsessive-compulsive disorder is. If you ever hesitate, clinical setting, shelf exam, as to what OCD is, simply look at the actual title of the illness, because within that title, you actually get the DSM criteria. It is that easy. An individual with OCD is suffering from either obsessions and or compulsions that are clinically significant, period. Now, there are some specifiers. It could be tick related, or you could see, again, there could be different degrees of insight. But the core of the definition, that first bullet, is literally hidden in the title of the disorder itself. Again, obsessive-compulsive disorder is defined through clinically significant obsessions and or compulsions. If somebody presents to you with clinically significant obsessions, clinically significant deficits in thought content that you deem are obsessions, they have OCD. If they present with clinically significant compulsive acts or behaviors to undo those persisting thoughts, they have OCD. If they present with both, they have OCD. Right? So it's that straightforward, and it should be that straightforward on a shelf exam. Again, if you ever hesitate, simply look at the actual title of the illness. The DSM criteria are contained in the title, Obsessive-Compulsive Disorder. There are obsessions, there are compulsions, there could be both, and the individual experiencing them is disordered. And we've went through this various times as well. And this is certainly something that the APA task force specifically looked at when publishing the DSM-5. To consider something disordered, it must be clinically significant. It must result in clinically significant distress or impairment. So it's all there in the actual title of the illness. This is the definition of compulsions. Again, whereas obsessions are deficits in thought content, specifically themes, compulsions are behaviors, the repetitive behaviors or mental acts, counting, etc., that the individual feels driven to perform to alleviate or reduce anxiety. Counting, cleaning, okay? Those are compulsions. If you have to, again, reference a visual video, we do have a library. I believe this is still active per the medical school. Dr. Glendenning actually purchased this. You could always refer to this to then get a visual of patient, just in case you do not come across this during your 5 weeks of the rotation. And if you do watch the video as a reference, you could then refer to this slide in terms of the mental status exam findings that are pulled from that very video clip. Again, keeping with the acronym as presented to you in a prior PowerPoint, ABC stamp liquor, those components or domains of a routine mental status exam. Now, obsessive-compulsive personality has nothing to do with obsessive thoughts. Obsessive-compulsive personality has nothing to do with compulsive acts or behaviors. Obsessive-compulsive personality instead focuses on perfectionism, order, and control. It is the type A personality. If you ever see OCPD on a test, stop yourself. Simply change that terminology to type A personality, and I think everything that defines OCPD then becomes very obvious. And hopefully then will have you avoid confusing that condition, the personality disorder, with this condition we're discussing today, the anxiety disorder, specifically obsessive-compulsive disorder. So despite the fact that there are shared clinical terms in the respective titles, OCD, OCPD, and despite the fact that one is ego-syntonic, that is consistent with one's values, versus ego-dystonic, and that is true, the differentiation is so much more obvious. I mean, it would be basically saying that the difference between the Empire State Building and the Seaside Heights Boardwalk is that one is in New York and one is in New Jersey. And that's true, but there's a difference between a boardwalk and a skyscraper that you probably should attend to. So the difference between OCD and OCPD is that one is defined through obsessions and compulsions, while the other, the personality disorder, has nothing to do with obsessive thoughts or compulsive acts, but everything to do with perfectionism, order, and control, that is type A personality traits. Now, the next question is, if that is the case, and that is the case, why in the world would the APA use common terminology if not to confuse medical students? Any guesses as to why in the world these two really separate conditions. One is the perfectionist, the other one is the person who continues to count or clean. Why in the world you would name them similarly? Because a lot of people, including psychiatrists, get very confused one versus the other. Thoughts? And the answer is you're looking at it. Way back when, in discussing the etiology, the thought is that both of these separate conditions shared a common etiology. And those etiological determinants are defense mechanisms, specifically the defense mechanism of isolation of affect and the defense mechanism of undoing, right? And this is actually held up because what we've seen now in the most current medical literature is that there is significant comorbidity when you look at these two conditions, kind of supporting the idea that they do stem from the same or common etiology, specifically isolation of affect and undoing. So let's get into this a little bit more specifically because the real focus is on that first defense of isolation of affect. So if somebody could share, anybody here sports fans? And if so, what's your team? We don't have a single sports fan in this rotation. How about if somebody fakes it? Give me a sports team.
The Patriots.
Patriots. Perfect. All right. So, and I'm glad we're faking it because I don't want this to get personal. But let's say a medical student who owns the Patriots, that is their sports team. They're a fanatic. That is, they're a fan. Wakes up one morning to find out that not only are they still struggling with Tom Brady, the chatter that he's going to be leaving the Patriots as a free agent, but then the breaking news that he has now signed a contract with the Tampa Bay Buccaneers. That person comes to work. They're a medical student. And on rotation, they happen to meet up with their attending who asks, because they see the Patriot button, hey, how about the breaking news on Tom Brady? So again, for the person who wants to fake this and be in character, very simply stated, are you looking forward to this conversation or are you not looking forward to this conversation? We'll make it real simple, A or B. Anyone?
Not looking forward.
I think that's fair. I mean, if you poll 100 Patriot fans, including Mark Wahlberg, and the energy behind this type of conversation, the day that news broke, no way are they looking forward to the conversation. Now, there's a couple of things, we could do. Unfortunately, when you're talking to an attending physician, there are certain rules in play that about 99% of the things you would like to say to that person, you're not going to be able to say to that person. That's called the superego, and that's called the reality principle. And it's basically the way our parents told us how to interact with people in general, and certainly authoritative figures in particular. So you may, if I was the one speaking with you, you may not tell me to go take a walk. So that emotion, that impulse is going to be thwarted. And that's thanks to your superego. That is the reality principle governing that aspect of your personality, the superego. So you got a problem here. Freud says that when you are not allowed to do what you feel you want to do, if your id impulse is not allowed to come to conscious expression or awareness, you're going to be anxious. That's the very definition of anxiety, the friction between the id and the superego. So now you're anxious. And what a wonderful way to start off a rotation. What a way to start off your workday. How does one alleviate anxiety? And no, you're not going to reach into your white lab coat pocket and pull out an Ativan. Any guess as to what internal mechanisms are built that alleviate or reduce anxiety? Well, there's a third part of your personality called the ego, and that's the part of the personality that it's going to now take front and center because it is or are the ego defense mechanisms that will alleviate anxiety. And there are plenty. One of which is isolation of affect. Isolation of affect will allow you to make eye contact with your attending physician during this conversation, but isolate the emotion so that you can engage in this discussion and simply not be emotionally invested in it. So individuals who do this come off as being a little robotic, a little bit overly intellectual, but they're able to get through that type of conversation by not being emotionally invested due to the ego defense called isolation of affect. And we've all done it, right? We've all kind of engaged in these discussions when we want to know part of the discussion. And I only use sports as an example. Now, there's a problem, and that is this may have gotten you through this discussion with your attending at 8 a.m. in the morning. However, that is not going to be curative. That is, anxiety is going to begin to get ramped up again. That is, this impulse cannot stay isolated, cannot stay in your subconscious indefinitely. And as it comes closer and closer to conscious awareness, you are going to experience that as greater and greater anxiety levels. So you're going to have to resort to a secondary defense. If that secondary defense is undoing, right, the ritualistic act of alleviating anxiety, counting, cleaning, checking, you're going to present to clinical practice and you are likely to be diagnosed with OCD because you will be manifesting these compulsive acts that perhaps are clinically significant. So you could see how these two ego defense mechanisms, when paired, can result in the diagnosis of obsessive compulsive disorder. On the other hand, if an individual employs isolation of affect and now hours to days later has overwhelming anxiety because that isolated affect is getting closer and closer to conscious awareness, if they employ reaction formation, that inner chaos is very likely to be turned around into its 180-degree opposite and expressed through perfect perfectionism, order, and control. That is, traits that are defining of obsessive compulsive personality disorder. So the reason why OCD and OCPD are similarly named is because of a common etiology, specifically isolation of affect. If the secondary defense is undoing, OCD is likely the single best answer. If that secondary defense mechanism is reaction formation, then obsessive compulsive personality is likely the single best diagnosis. For OCD, treatment, like treatment for any condition, is going to be biopsychosocial. That second bullet toward the middle of your screen looks at a couple of pharmacological alternatives, those medications that are FDA approved. There are several SSRIs that are approved for multiple anxiety disorders, including OCD. And the tricyclic antidepressant, abbreviated TCA, called clomipramine, has significant serotonergic reuptake blockade, resulting in it being FDA approved for the treatment of OCD as well. So pharmacologic therapy, again, the bio part of biopsychosocial includes SSRIs as a class, multiple agents within that class, as well as the single TCA agent called clomipramine. Before we get to our next condition, any questions about obsessive compulsive disorder? Any questions about OCPD? All right, this case was actually pulled out from a retired shelf question. 45-year-old presenting with a chief complaint of panic. reporting insomnia for several years, for which they recently underwent a sleep study. The sleep study revealed a pathology for which they were prescribed modafinil, which is a stimulant. Now the patient presents with new onset anxiety, irritability, and tremor. Most likely diagnosis? Anyone care to take a stab? This is a substance-induced anxiety disorder. This is a side effect of the modafinil. Individuals with this condition demonstrate anxiety that is due to the direct and physiological effects of a substance. The substance could be a medication, as was in the clinical vignette. It could be illicit, it could be a toxin, it could even be an herb. Although this reference was from 1994, it's an old reference, these medications still stand today as the biggest culprits of inducing anxiety. So anything that will increase sympathetic tone, anything sympathomimetics can do, anticholinergics can do just as well. Thyroid hormone commonly comes up in exams, as does the steroid. And finally, any methyl xanthine derivatives, over-the-counter cold remedies, arthritis, and of course, theophylline used for COPD. So again, very common on exams, sympathomimetics, anything that increases sympathetic tone, anything that decreases parasympathetic tone, aka the anticholinergics. If you look at the illicit substances, here's your list from the DSM. We're looking at substances from the intoxication state as well as the withdrawal phase. I think for intoxication, it's best to remember that all drugs can, with 3 exceptions. When you look at the withdrawal phase, there are 4 drugs that can induce anxiety during their withdrawal. So here's just a quick list of those substances that both during their intoxication phase as well as their withdrawal states can induce an anxiety disorder. The T, trichotillomania, is new to this chapter. This condition was formerly in the impulse control disorders chapter, but because of its close relation with obsessive-compulsive disorder, trichotillomania was moved to one of the 3 anxiety disorders chapter. It is in the obsessive-compulsive disorder, I should say the obsessive-compulsive and related disorders chapter specifically. Yes, it is a disorder related to OCD. Here, the condition is defined through recurrent pulling of one's hair, which often results in hair loss. There are repeated attempts to decrease or stop, which are unsuccessful. Next case, we have a 30-year-old presenting with chest pain. They report that they're afraid of having a panic attack, or a heart attack. The history of present illness is consistent with palpitations, with 3 similar episodes in the past month. They are a smoker. Most likely diagnosis? Anybody want to take a stab? This is panic disorder. Panic disorder is defined through recurrent unexpected panic attacks. All right, so this condition is a chronic condition of episodic illnesses or episodic syndromes. Of course, it has to be clinically significant, but I want you to take a little bit of a closer look at clinical significance here, because there are a couple of points to make. Number one really is agoraphobia. I want to mention that again, agoraphobia is a freestanding condition. We're going to get to what that means in just a little bit. But it is also an example of a change in behavior. An individual may or may not have agoraphobia, but they can still rule in for a panic attack, and therefore they can still rule in for panic disorder. An individual may tell you reliably that they have no change in behavior. But if they have a month of worry or concern, that still rules in as clinical significance. So be very careful. Do not look at the absence of agoraphobia to have any negative predictive value in diagnosing a panic attack and therefore panic disorder. So that then results in, well, what is a panic attack then? Again, I want to make the point that this condition, a panic attack, can occur in the context of any mental disorder, not just in panic disorder. And again, biopsychosocial, and what this slide looks at in terms of some biological factors contributing to a panic attack is further broken down into those factors that may precipitate and predispose to the panic attack as well. So I tried to merge these different concepts on how to address etiology, that is biopsychosocial, now combined with the 3 Ps. Predisposing conditions, precipitating, and then even perpetuating, which does not appear on this slide. A panic attack is a discrete period defined by intense fear or discomfort in which 4 or more symptoms develop abruptly, usually described as coming out of the blue, reaching a peak within 10 minutes, and then usually lasting about, on average, 30 minutes, maybe as long as 60 on average. If you look at the 4 symptoms, I pulled this from brain calipers. There's a couple of things I want to point out here. Number 1, again, the acronym, if it serves you well, please use it. This is not fun. I didn't have enough slide space to actually break up the words. This is not fun. Again, this is taken from a book that I often reference for acronym purposes. Having read through the Dsm criteria, and again, these are all Dsm criteria, reshuffled to spell out this is not fun. The one thing I want medical students to convince themselves is that if somebody presented with these signs and symptoms, 4 or more, what they're looking at, what they're observing is clinically indistinguishable from a heart attack, from an acute MI. All a panic attack is on a shelf exam is an acute MI without evidence of myocardial ischemia. That's what you have to know here. So this is a nice little acronym, but this is one that I don't think you're going to have to use. You just have to convince yourself that this is an MI. And when an MI appears on a shelf exam and you get an EKG and you get cardiac enzymes that are not indicative of acute myocardial ischemia, the single best answer is going to be a panic attack, and if recurrent and clinically significant, panic disorder. You could also see that when you bunch up, and again, it's very nice that that this acronym in succession has the I, S, N, and O, because all of these contribute to the subjective sense of the room spinning, vertigo, and the title of the film that further, I think, demonstrates anxiety disorders that we will discuss in more detail tomorrow as a fictional case of one of these anxiety disorders. Agoraphobia. Agoraphobia is a term that originally came from the Greek meaning of fear of the marketplace. Specifically, it's about anxiety about being in places from which escape may be difficult. And again, often associated with panic, but can certainly be a stand-alone illness, as I mentioned before, agoraphobia. Now, this is a great example. That is, agoraphobia is a great example of one of the points that I brought up during the introduction slide, the objective slide, and that is there is going to be phobic avoidance. And when you see avoidance on a psych shelf, or quite frankly, any other shelf, be very careful. Read the entire question closely and know some specific point you want to look for. Case in point, if you're looking for anxiety about being in a place from which escape may be difficult, if you uncover that, agoraphobia is going to be the best explanation for the avoidance behavior. There are some specifics you can look for. Again, fear of the marketplace. One of the things you might buy at a market is a peach. And there are 5 examples of which the DSM says you need at least two: parking lots, enclosed places, automobiles, crowds, and then the H stands for outside the home alone. The H is the letter of home in outside of home alone, that fifth criterion. So these are some of the things I want you to keep in the back of your mind. I think the much more important concept to make sure you understand going into your shelf is that it is fear of escape or being embarrassed and not being able to escape in time. Any phobia, any word that includes phobia as a root is likely the result of displacement. Displacement is a defense mechanism. Many people, many clinicians, and I include Freud's initial case here, will often describe the phobic object as being nothing more than a displaced object. And the root of what you would provide in therapy, usually either dynamic therapy or analytic therapy, is really finding out what the individual is truly afraid of. In as much as, for example, as this slide may propose, the horse being just a symbolic phobic object of one's true fear. Now, when an individual presents with phobic avoidance and you do not see that it is due to fear of escaping in time, but instead something else, you have to move away from agoraphobia. Now, social anxiety disorder may actually be a remnant of something that is completely normal, that is developmentally appropriate. When the individual is older than 18 months, it becomes inappropriate and therefore defining of separation anxiety disorder. So this condition is defined as developmentally inappropriate anxiety concerning separation from attachment figures. Usually in a child. Now, again, on shelf exam, since this normally developmentally peaks at 18 months, you are not likely to get a 19-month-old, right? So a child, but one who is significantly older than 18 months. The symptoms, because it is a child, or usually a child on a shelf exam, is usually communicated non-verbally. So somatic, behavioral. Very infrequently will a child present with a chief complaint of anxiety. This condition is defined by where the individual is separating from rather than where they're going to. Right? So fixation, regression, maybe defense mechanisms involved in this, but again, there's got to be some evidence in your clinical vignette that it's separating from the maternal/parental figure, not necessarily where they're going to, that is invoking the anxiety. And when you see that in a clinical vignette, the cause or the reason for the avoidance behavior is likely separation anxiety disorder. Social anxiety disorder, aka social phobia, again, may present with clinically significant avoidance behavior, but the fear is different yet again. Here, it has nothing to do with where they're separating from. Here, it has nothing to do with fear of embarrassment. It is the social or performance situation itself that invokes the fear. The common example is performance. And therefore, the American Psychiatric Association has created a performance-only specifier. So it is so common, aka performance anxiety, that it's become a specifier of social anxiety disorder. You're often asked about treatment. If you need something that is quick acting, that is, if there is a grand rounds that you're providing next week, there's not going to be enough time for therapy. Therapy is always the single best answer unless you need a rapid response. Rapid response needed, propranolol becomes your single best answer. If an individual has third-degree heart block, or if they have asthma and the beta blocker is otherwise contraindicated, consideration for an alternative second-line agent, such as a benzodiazepine, should be considered. Otherwise, the single best answer is always going to be psychotherapy. And there is some evidence that psychotherapy alone may be actually more effective, specifically cognitive behavioral therapy or CBT. Next case is a 65-year-old that presents for treatment of panic, reports a long history of insomnia, being easily startled, and intrusive dreams. This could have very easily been, that is the presentation, avoidance behavior as well. Most likely diagnosis is in the acute stress and post-traumatic stress disorder continuum. There's a history here of actual or threatened death, serious injury, or even sexual violence. This could be experienced directly, experienced indirectly, or perhaps witnessed. Individuals avoid. Okay, so again, very commonly presents with clinically significant avoidance, not unlike separation anxiety disorder, not unlike social anxiety disorder, not unlike agoraphobia. But here, what you're going to be specifically looking for is different. That is, there are multiple additional signs and symptoms that help define and therefore distinguish this condition, or these conditions, plural, from the others that may present with avoidance behavior. This is the acronym. STOP, she is afraid. There are 3 criteria sets, the first of which defined through STOP. This slide is for further clarification and how this may relate back to the film Vertigo. Again, a film we're going to be flipping tomorrow over Instagram Live, as well as a shared Zoom link that I think portrays some evidence that there might be aspects of post-traumatic stress versus acute stress disorder in the fictional case study titled Vertigo. The second criteria set, she is, here. Again, on the right side of your slide, we see evidence supporting criteria as part from this criteria set, often titled the arousal criteria. And then finally, afraid, the third and final criteria set here. Individuals with this condition may have aspects of depersonalization and or derealization, or not, but now these dissociative symptoms are qualifiers or specifiers. You'll often hear people refer to complex PTSD. All that means is post-traumatic stress disorder that includes dissociative symptoms, depersonalization, derealization, or both. Here, these next 2 slides, I give you specific examples. I won't go through these slides with any real detail, but certainly examples and further details of these dissociative symptoms, and as they certainly are portrayed in the film Vertigo, which we'll get into a deeper dive tomorrow. And then finally, the differentiation between acute stress disorder and post-traumatic stress disorder, that is that cutoff being 1 month, right? So 1 month or less, we're going to call it acute stress disorder or ASD. Greater than 1 month, we'll call it post-traumatic stress disorder, PTSD. When medical conditions, when occult medical conditions present with behavioral signs instead of physical, we then begin to think of conditions like anxiety being the direct physiologic result of that very medical condition. And these are some of the more common ones that come up on exams, just for your review, so that you can identify them on the shelf. A condition, and I wasn't afforded the juxtaposition as I was the 2 prior pairs, but the condition of excoriation disorder is related to trichotillomania. Again, new to the DSM, this condition is defined through recurrent skin picking that result in lesions. Very similar to trichotillomania, we're just exchanging hair pulling with skin picking, excoriation disorder. And then finally, specific phobia. Specific phobia is a fear, an irrational fear that's cued by an object or situation. In specific phobia, we have 4 base categories: BASE, blood, injection, injury; animal, situational and environmental. And again, I think there's a great example of situational type of specific phobia in tomorrow's case discussion of vertigo. This is by design a copy and paste. Any disorder that includes the root phobia is thought to be a result of displacement as per psychodynamic or psychoanalytic theory. There are multiple other theories, including behavioral and cognitive behavioral. And I think the behavioral theory is expanded upon, at least in one scene in tomorrow's case. And it's this very scene here. Again, a scene that I will certainly bring up and provide greater detail during tomorrow's didactic. This is just a quick spoiler alert, but again, for your handout, I wanted to make sure you had it, especially for tomorrow's discussion. These are additional themes of the movie, again, to be discussed tomorrow that are outside of the anxiety disorders chapter. And then finally, just a quick blurb about what to expect for tomorrow. We're going to have a didactic that is joint with Texas Tech University. This will be provided over Zoom, although we will also be on Instagram Live as well. The reason why we're going to do the live broadcast that is so that we can upload the recording for students that don't have time available to actually participate in the discussion itself when it's in real time. That recording will be uploaded to our YouTube channel by Friday night. So if you miss out, you can certainly listen to the recording as well. What's really interesting is that Vertigo is the first movie to use dolly zoom to provide that sense of disorientation, aka vertigo. And this actual effect was used also in the 1975 film Jaws, as you see here as well. And it was just coincidence, eerie coincidence nonetheless, that we are discussing Jaws tomorrow as well. That was just by chance. So join us tomorrow. That'll be 12 noon on Zoom for case discussion of what Jaws and vertigo are really about. Before we end here, I'll stop sharing my slides. Any questions? All right, if no questions, again, we'll see everybody tomorrow. That'll be 12 o'clock on Zoom. And for those of you who can't make it, again, the recording of tomorrow's conversation, fictional cases of Jaws and vertigo will be uploaded to our YouTube channel for you to access and listen. Thank you.
Thank you.